teacher, scholar, loved the outdoors, and I think this whole foundation that relates to this lectureship was really a family, driven, ultimately, outcome. So I'm privileged to be one of many very famous people, and I probably don't belong in that list with other people. All right, so let's see if we can advance. These are my duality of interest. Probably most of these don't relate to anything I'm going to say. Arrowhead, I'm on a data safety monitoring board for a clinical trial. Amgen makes a PCSK9 inhibitor. We're not going to talk about that today, as does Regeneron and Sanofi. I don't even have them up there. So most of these relationships are really not related to my talk today. Bob Rosenson at Mount Sinai and I write the up-to-date section on hypertriglyceridemia. I know you've all read that, right? Oh, okay. So you don't have to confess that afterwards today. All right, so here's the learning objectives today. Make sure I'm pressing the right button. The first is I'm going to discuss with you problems with the definition, related prevalence, and causes of hypertriglyceridemia. So that'll be the initial section. Oh, my bad, wrong one. Second, provide updates on if and how hypertriglyceridemia relates to atherosclerotic cardiovascular disease. And I think you may be a little bit surprised at what I'm going to say here. And finally, look at emerging strategies for the management of people with hypertriglyceridemia. We're talking about moderate levels, and we're going to talk about severe hypertriglyceridemia. So let's begin. The first thing I think you need to know clinically is if you look here at this plot, and this is a kind of a historic plot over 20 years old now, and this is shown for every large epidemiological study. When we look at HDL cholesterol levels and how they relate to triglycerides, on the left, when people have normal triglycerides, their HDL cholesterol can be all over the board. But when people get hypertriglyceridemic, their HDL cholesterol levels are low. So think about this as an expected outcome for people who are hypertriglyceridemic. They have low levels of HDL cholesterol. So what's the mechanism of this? Well, I'm going to describe briefly the mechanism. The first is the formation of larger, more buoyant cholesterol-enriched HDL is dependent on the hydrolysis of triglyceride-rich lipoproteins by lipoprotein lipase. And lipoprotein lipase is an enzyme that my lab has been devoted to for decades now. And we've studied it clinically in people with obesity and normal weight people, and et cetera, with muscle biopsies and fat biopsies, but we've studied it in genetically modified mice. And the lab that I ran for many years is taken over by Kim Bruce, a very talented PhD. All our work now is in the brain. And you may not think lipoproteins do much in the brain, but boy, I'll tell you, they do a lot, and they relate to neurodegenerative diseases. I'm not going to bore you with that today. But look at this slide. This is important because chylomicrons and VLDL are the major triglyceride-carrying lipoproteins. Lipoprotein lipase is an enzyme on the glycan calyx bound by a GPI HDL binding protein, and the hydrolysis of these triglyceride-rich particles ultimately gives rise to a lot of unesterified cholesterol and phospholipids that find their way to HDL cholesterol. So when people are hypertriglyceridemic, they may not be clearing their triglycerides very well, and the fall in the level of HDL relates to the fall in this more buoyant form of HDL because of the inadequate transfer of surface cholesterol and phospholipids. Think about this for a second. If you think of lipoproteins, what are they there for? They're there to carry lipid. And ultimately, the unesterified lipids like triglycerides and cholesterol ester are the core of the particle. That allows lipoproteins to be miscible in plasma. But as triglycerides go up, I'll remember as my training experience in the University of Washington, John Brunzell, one of my mentors, used to hold plasma up and kind of predict what the triglyceride concentration was. And once you get up around 200, 250, you start getting turbidity. And that turbidity increases because as triglycerides go up, there's less capability of solubilization of the particles in the plasma. So ultimately, a second mechanism is when hypertriglyceridemia is present, the HDL particles are more triglyceride-rich, replacing cholesterol with triglycerides in the lipoprotein core. Okay, so HDL has very little triglycerides, less than 5% of its mass. But when you're hypertriglyceridemic, there's more triglyceride that replaces the cholesterol ester, so HDL cholesterol levels are much lower. And when you measure cholesterol in the lipoproteins, most of it's in the core of the particle. It's not surface unesterified cholesterol. It's cholesterol ester. And the third is work by Ira Goldberg, then at Columbia, now at NYU, who showed that triglyceride HDL are more rapidly catabolized and excreted in the kidney. So maybe too much information for you, but that's why HDL cholesterol levels are low in people that are hypertriglyceridemia. 3 biologic explanations. Now, what are some of the problems with evaluating and treating hypertriglyceridemia? Let's begin with defining the disorder. First of all, the common disorders are not single genes, okay? The acquired disorders are numerous. We'll review those sequentially. The clinical trials with triglyceride-lowering drugs have suffered, and they've suffered because of design. The number of trials are fewer than cholesterol-lowering trials, and the results have been mostly hypothesis-generating. We'll come back to that. And finally, is it the triglycerides themselves or the particles that carry triglyceride that confer risk for atherosclerotic cardiovascular disease, or is it the company they keep, like low HDL cholesterol? That's really a critically important question, and I'm going to answer that, I think, and I hope definitively this morning. So fasting values are highly variable. So here, if we're looking at the diurnal biologic variability and the monthly biologic variability, look at the variability of ApoB and ApoA1 and LDL cholesterol, by the way, calculated or directly measured, and diurnal variability of triglycerides and monthly variability. They vary a lot. And ultimately, if you have a couple drinks the night before, your fasting triglycerides may be 20 or 30% higher. It relates to nutrition, relates to physical activity. There's lots of things that change triglycerides a lot. So I think that's another reason why triglycerides are a little bit more problematic in terms of evaluating. And you've all seen in your clinics, if you're taking care of people measuring lipids, triglycerides could be 114 one time and 210 the next. I mean, they vary a lot, and you can't make good decisions when you see that variability. And work by Mahmoud Abdel Mahmoud, who was in my lab and worked with me on this particular study, we actually showed that variability of triglycerides, and I'm not going to go through the statistical evaluation with a multivariate analysis at the bottom, but ultimately that relationship related to coronary heart disease development in a mixed population of Hispanics and Caucasians in the valley in the southern area of the state of Colorado. So this variability in triglycerides may be relevant to ultimately cardiovascular disease to follow. Okay, so fasting levels are variable. I've shown you that. Population data are skewed. So a bell-shaped curve is not what we see skewing to the right. So if we look at the bell-shaped curve, we have more people on the right side of the curve than we have very low levels on the left. So all the data, if you look at epidemiologically for triglycerides, tend to be logarithmically transformed because of that skewing to the right. The relationships to coronary heart disease often fail to relate to the extent of elevation, so we'll come back to that. And what's a normal triglyceride level? I mean, I always kind of thought age plus 100 is probably a better way to think about triglycerides, because with aging, triglycerides tend to go up a little bit, but no guideline uses that definition. Is it the fasting triglyceride less than 150? That's kind of what people say. Or it should be based on non-fasting levels. And we're not going to go there this morning, but there's increasing data that say you don't have to measure triglycerides after a 12-hour fast. Clinical trial data, epidemiological data suggests that non-fasting triglycerides are as predictable of outcomes as fasting levels. The only problem with non-fasting, if you're using the Friedewald equation to calculate the LDL cholesterol in the laboratory, dividing the triglycerides by 5, that can be flawed a bit if you're getting non-fasting levels. But if you look at the epidemiology or predictability of high triglycerides and coronary heart disease outcomes, non-fasting is as good as fasting. Now, is that recommended? It's funny, you know, we're all patients, we're all docs or in healthcare professional roles one way or the other, but my own primary care physician doesn't want my lipids to be done fasting. I said, but Steve, no, Eckel, get them done non-fasting. So anyway, I'm a patient now more than I am a doctor. Okay, so here's the definitions, and I don't want to go through this in great detail, but if you look at the ACCA, American Heart Association at the top, the European Society of Cardiology, the Endocrine Society, and then you're looking at what Bob Rosenson and I have published in UpToDate, which is the right answer, of course. No, I'm just, but this is the simplest way to think about TGs. We're going to say less than 150 is normal because everybody else says that less than 150 is normal. Moderate hypertriglyceridemia is defined as 150 above all the way to 500. Why that cut point? And by the way, it's not all that different from all these other societies. It's because above 500, you're starting to get into areas where you may be saturated for triglyceride removal. I'll return to that in the therapeutic part of the talk. So between 500 and 1,000, And when I spoke to medical students over the many years, I used to say, if you have a patient whose triglycerides on a Friday are 650, and they have 3 cases of beer, they're sedentary and watching 15 NFL and college football games over the weekend, their triglycerides on Monday could be 2,000. Because you're getting to the place where saturation kinetics exists. And again, we'll come back to that in more detail here. And moderate to severe, 500 to 1,000, because this is a zone where, in fact, we think people can get more seriously hypertriglyceridemic, and then severe defined by above 1,000. I'm not sure where we got that thing at the bottom, but that's okay. Above 1,000, don't play with this. We're fine, really, Raj. So I think above 1,000, you need to get attention. In our laboratory at the university, we have a red symbol for severe hypertriglyceridemia because a physician needs to be called. You don't want people going, on their own lifestyle kind of plan when TGs are that high, because acute pancreatitis, 5% fatality. And I think the reason you don't see those in the hospital is people have hemorrhagic pancreatitis that die at home of shock, okay? All right. So what's the overall prevalence of defining TGs of above 150? Well, the overall prevalence in the United States, the most recent NHANES data, is 2007, 2014. I keep trying to update this, but I've not been successful. I don't think it's really changed very much. Maybe it's a little bit higher. 26%. Statin-treated people higher. Why? Because they're on statins for other lipid disturbances. So a little bit higher. Statin-treated with diabetes, 40% of people with diabetes are on statins, have TGs above 150. Statin-treated with atherosclerotic cardiovascular disease, we're doing a little bit better there. And ultimately, statin-treated diabetes and ASCVD, about 1/3 of the population has TGs above 150. So that's the prevalence, at least in that time period. All right, so let's look now at the very important question that I told you I'd try to answer for you here today. She's kind of pondering, as he doesn't look like he's very interested, but she says, does hypertriglyceridemia cause cardiovascular disease, or increased triglyceride levels simply a risk factor by association only? So let's see if we can answer that question. Multiple studies have shown the relationship between triglycerides and coronary heart disease risk. No matter whether the follow-up's less than 10 years, greater than 10 years, whether you're a man or a woman, whether you're fasting or non-fasting, by the way. And adjusted for HDL cholesterol, remember, HDL cholesterols are low when people have triglycerides that are elevated. So if you modify that risk based on the low level of HDL cholesterol, you're going to see a reduction of that risk, but it's still very positive. Now, here's just one of maybe hundreds and hundreds of studies that show here elevated triglycerides are independently associated with increased all-cause mortality in people with established cardiovascular disease. The previous data related to risk 4, now we're talking about people with existing atherosclerosis and the role, or at least the contribution, of higher levels of triglycerides. Now, this is a paper that Ira Goldberg and I and Ruth McPherson from Canada published a number of years ago, but this is still a valid way to think about this. What's the role of triglyceride-rich lipoprotein metabolism in causing atherosclerosis, in fact, if this is causative? Well, the idea comes from two types of approaches. One is, I guess we don't have a poll. Oh, here we are. Okay, one is the remnant hypothesis, which is one in which the action of lipoprotein lipase reduces particle size. And by the way, remember that almost all LDL comes from the hydrolysis of VLDL by lipoprotein lipase. And people that have no lipoprotein lipase, their LDL cholesterols are 5 or 15. I mean, they're incredibly low because this hydrolysis reaction makes LDL produced. Now, the liver makes LDL directly in a small amount of maybe 10% of LDL comes from direct secretion. So the remnant hypothesis is the idea after the particle size is reduced, these particles get access to the extracellular space and ultimately get oxidized and acted upon by macrophages and develop foam cells. The other idea is lipoprotein lipase effect on chylose or VLDL causes a release of products, including fatty acids, that may in fact modify levels of inflammation, adhesion molecules, et cetera, that relate to the atherosclerotic process. So those are the two models that are thought to how the atherogenicity of TG-rich particles occurs. Now, I'm going to go through this fairly slowly, but here's the chylomicron produced by the gut down here. I'm not sure we can see this very well. Well, lower right, the bigger particle, and then to the left. And if you see these question marks with red boxes, That's the unlikelihood that chylomicrons themselves are directly causative of atherosclerosis. The particles are huge. They're like 5,000 angstroms, some of these very, very big particles. And we know people with LPL deficiency who have chylomicron elevations that cause TGs of 5,000 or 10,000. Those people don't get atherosclerosis. We'll return to that too. But the, excuse me, the VLDL shown down here on the left, made by the liver, the large VLDL probably, like chylomicrons, are too big to get in the subendothelial space. And that's where atherosclerosis occurs. But look at these remnant particles, so-called remnants. These are byproducts of lipoprotein lipase that I showed on the previous slide that now become relatively cholesterol enriched. And that may relate to why small, dense LDL are more likely to be associated with atherosclerosis because they maybe have greater access to the subendothelial space. And so I think these types of biologic and physiological studies really probably indicate that triglycerides may in fact not be causative, but may be related to the particles that carry triglycerides once they're reduced in size. You know, when we eat a high-fat meal, ultimately, what's the half-life of chylomicrons? 3 or 4 hours they peak, and they're gone by 5 or 6 hours. We have people fast for 12 hours, but you probably don't need to do that. Normal people could probably get lipids measured in 6 hours, and their TGs are back to normal. But when you're hypertriglyceridemic, let's say levels 300 or 400, you may take 10 hours to clear those triglycerides. But anyway, back to the issue. The thought here is maybe since triglycerides are carried mostly in larger particles initially, maybe this is association in the cause and effect. And here's just an example, postprandial hypertriglyceridemia. Now, that slide, unfortunately, this thing up here on the right is blocking this a little bit. But that red bar are remnants, which again are these byproducts of lipoprotein lipase after people eat. Now, this is postprandial hypertriglyceridemia, and the levels of triglyceride are shown here at the bottom. 1 millimolar, by the way, is about 90 milligrams per deciliter. And if you look from the millimolar concentrations from left to right, you're looking at increasing levels of remnant particles in red. And of course, the far bar on the right up to 6 millimolar, which would be, do the math, 540 milligrams per deciliter. That red bar is almost down to where that black box sits. And I don't know if we want to mess with that to try to get rid of that, but I'm just making a point that these remnant particles relate to eating and the generation of particles that are much more cholesterol enriched after lipoprotein lipase acts on the triglycerides. And the blue bar, by the way, is LDL, and the green bar is HDL. So the red bar are these particles that are formed by the hydrolysis of triglyceride-rich particles by LPO. Okay, next question. We got to think of everything as being genetically conferred or acquired. So what about genetics? The concept of autosomal dominant genes, familial combined hyperlipidemia, and familial hypertriglyceridemia, when Joe Goldstein, who's Nobel Prize for the LDL receptor, was in Seattle as a genetics fellow, and I came right after he went to Dallas, ultimately, they defined a condition based on simply family studies of familial combined being a genetic disorder where triglycerides are high and cholesterol is high, and familial hypertriglyceridemia as triglycerides only are high. And that is a flawed hypothesis. I'm not being critical of a Nobel Prize laureate, but I'm just saying at that time the genetics were very simplistic. But ultimately now it's been clear that there are a number of polymorphisms that have been identified that relate to hypertriglyceridemia, and these single genes for familial combined and FHTG are no longer relevant. It's not true. Those are not single genes. So here's an example of a series of polymorphisms that relate to hypertriglyceridemia, including ApoA5, the glucokinase receptor, lipoprotein lipase, TRIB1, transcription factor, angiopoietin-3, and on down the list. You don't need to remember all this. It's simply that all of these genes have polymorphisms that relate to hypertriglyceridemia. And what Rob Hageley's group in Hamilton has demonstrated now, if you look at hypertriglyceridemic people versus controls, and you look at the risk score for hypertriglyceridemia, this is incredibly additive in terms of how many alleles you have modified. And in the clinic, I'd occasionally, in a patient who I don't have a very good explanation for why they're hypertriglyceridemic, I would send DNA to Rob. And ultimately, if they had 2 or 3 alleles that were modified, had SNPs, I didn't get very excited. But when people have 15 or 18 of these alleles that are modified, there's an additive effect. And that's what's shown here in terms of the levels of triglycerides, comparing 344 people with hypertriglyceridemia to a control population. Now, another approach to the genetics, what we're looking at here are studies by the Brigham group that look at LDL-related alleles here at the top. There we are. Here we're looking at HDL, and here we're looking at triglyceride-raising alleles. What's interesting here is LDL-raising alleles and triglyceride-raising alleles look at the impact on cardiovascular disease risk here, acute myocardial infarction. But look at HDL. HDL, there's no genetic contribution at all to cardiovascular disease risk. And so your levels of HDL, although they inversely relate to coronary heart disease, relates to your behavior, your lifestyle, et cetera. They're acquired causes, not genetic. Now, if you look at this a little bit further for triglycerides, ultimately we need to return to the fact that ApoB is an interesting apoprotein. There's only one ApoB molecule per VLDL made by the liver, only one ApoB on VLDL remnants, and only one ApoB on LDL. So we're thinking about ApoB as the major apoprotein we think about with triglyceride-rich lipoprotein metabolism and LDL. Here we've looked at the Ference, Brian Ference from the UK has looked at a multivariate Mendelian randomization of how ApoB, triglycerides, and LDL relate to coronary heart disease risk. And I'm pointing you in this box. Everything is explained not by LDL cholesterol or triglycerides, but by ApoB. And look at that p-value. I mean, we're talking about 7.5 to the 20th level of significance. So ApoB doesn't cause atherosclerosis, but the level of ApoB genetically that's present confers the relationship of these lipoproteins to coronary heart disease here in terms of the randomization, Mendelian randomization approach. Now, another protein's become more apparent recently, and that's ApoC3. So here's a loss of function of mutations in ApoC3, triglycerides and heart disease that relate to a reduction in risk, loss of function, another paper related to ischemic vascular disease, and ultimately an antisense inhibition of C3 that reduces triglycerides. So this has been an area where companies have gotten increasingly interesting. Now, if we think of VLDL, the nascent particles can vary a lot. They can have only ApoB on it. They can have ApoB and ApoE. They can have ApoB and C3. And they can have ApoB and C3 and E. So all these particles are like vegetable soup. But ApoB is on all these particles made by the liver. Okay, so now if we're thinking about how ApoC3 relates to atherosclerosis, we need to think more clearly that why ApoC3 may be harmful. Number one, it's increasingly secreted in insulin-resistant states. And remember the prevalence of hypertriglyceridemia in people with diabetes. So metabolic syndrome, type 2 diabetes. Itself, ApoC3 can increases in protein kinase C beta and cause more insulin resistance. So this is a feedback mechanism by which ApoC3 may breed additional insulin resistance. Interestingly enough, the pro-inflammatory downstream product, NF-kappa B, increases ApoC3 gene expression. This protein decreases LPL and triglyceride-rich lipoprotein metabolism. It decreases the binding of ApoB lipoproteins to hepatic BE receptors for clearance in the liver. It increases the adherence of monocytes to the endothelium. So ApoC3 does lots of negative things and finally activates monocytes. So bad protein. And so that's why the companies that are in this space are really interested in making inhibitors of ApoC3 to modify triglyceride-rich lipoprotein. But before we go to the therapeutic aspects that relate to this, we got to remember the secondary causes of hypertriglyceridemia. And that includes diabetes and insulin resistance, obesity, alcohol, chronic kidney disease, nephrotic syndrome, hypothyroidism, HIV, hepatocellular disease, and inflammatory diseases. All these things relate to hypertriglyceridemia. But look at the drug list. Oral estrogens, bile acid sequestrants, antivirals, phenothiazines, particularly the second generation, non-selective, not selective beta blockers, thiazides, loop diuretics, glucocorticoids, immunosuppressants, tamoxifen, vitamin A, and propofol. I mean, this is a long list of drugs. All of these have modest effects. But if you have alleles that are specific for higher triglyceride levels, these drugs can have a much greater effect. Now, this is a very important slide. What we're looking at here is the relationship between levels of ApoB and non-HDL cholesterol. So what we're looking at here, by the way, the correlation between ApoB and non-HDL cholesterol is incredibly strong, looking at large numbers of people. But I'm not sure you treat 2,000 people. We treat one patient at a time. Look at the 95th% confidence intervals of ApoB around any given level of non-HDL cholesterol, by the way, which is free. When you measure a lipid panel, the non-HDL cholesterol level is simply the HDL subtracted from the total. That 95th% confidence interval is twofold difference. And if we're saying the relationship between triglycerides and heart disease relates to ApoB, then this could make a big difference. So let me give you an example of a patient that has fasting triglycerides of 300, and their ApoB now is 82 versus a ApoB that's 138. I mean, I'm going to really be approaching those patients differently if their ApoB is elevated with the same level of triglycerides or if it's much, much lower. So let's now approach how we figure out whether people with hypertriglyceridemia need to be treated. Heart healthy lifestyle, always, plenty of physical activity, weight reduction, dietary quality. And by the way, dietary quality is a lifestyle nutritional approach that relates to a dietary pattern. It doesn't relate to restriction of this or restriction of that. And when it's implemented, it's additional simple carbohydrate restriction may not be necessary because these dietary patterns, carbohydrates complex. It's not simple sugars, okay? Regular physical activity, the more active you are, the lower your triglycerides. 3 to 4 sessions a week typically is best. Fasting or lasting on average 40 minutes per session, involving moderate to vigorous intensive physical activity. And weight reduction, I think generally 10% is better than 5. 5 generally does cause modest lowering triglycerides, but you need to lose more weight to get it down. What about drugs? Here are the drug classes, the range of drug lowering effects on triglycerides. Keep in mind, statins at low end have no effect, basically. But if you get to moderate to high dose intensity statins, you get up to 35% lowering in triglycerides. Now, here's the fibrate trials, and I won't review them in detail. The only trials that have been positive are HHS and VA HIT. The Helsinki heart study, a really dated study now, was done with gemfibrozil. There were no statins. LDL cholesterol was 190 or 189 in that study. And so the modest effect of the cholesterol lowering probably explained the benefit, although there were people with high triglycerides and low HDL that seemed to benefit. And by the way, the primary outcomes in all these studies is a little bit different. You need to look at that. Then the VA HIT study, which was done in the VA of veterans that had low HDLs and high triglycerides. Again, gemfibrozil was a drug. The benefit was clearly there, and it was a 22% reduction, but did not relate to the amount of triglyceride lowering. That's an important study. Then look at all these other studies. BIP, LEADER, FIELD, ACCORD, and ACCORDION all had modest reductions in the primary outcome, which were all non-significant. And ultimately, the amount of triglyceride lowering had no difference. But ultimately, because the ACCORD trial showed that the people with low HDLs and high TGs looked to be more successfully modified in terms of the coronary heart disease outcome. Remember, no relationship to triglyceride lowering. The prominent trial was designed, which I was part of, ultimately as one of the scientific people up front in terms of designing the trial. This was to use a pemafibrate, a SPARM alpha, which had very high selectivity to PPAR, alpha selectivity, driving fatty acid oxidation. And there's the primary outcome, et cetera, but that trial failed to show any benefit. And the amount of triglyceride lowering had no relationship to outcome. So what's your conclusion? Do triglycerides cause heart disease, or are they associated with particles that carry triglyceride, including ApoB, that are related to heart disease risk? The JELIS study is a Japanese study done in a fairly small sample on modest dose pravastatin, showed a relationship in primary and secondary prevention, more so in secondary versus the total population, ultimately on reducing cardiovascular disease risk. Again, the amount of triglyceride lowering had no impact. And there's the difference in people that had high TGs and low HDL at baseline. Fairly small sample, but yet statistically significant with EPA alone, icosapentaenoic acid. And then there's the REDUCER trial, and here was a very strong study that showed a benefit of EPA only. And here's the outcome related to multiple cardiovascular disease outcome events. So that looked pretty good. Again, no relationship to triglyceride lowering despite the benefit of EPA. And here's the first, second, and subsequent events, all reduced by EPA. Series of papers, probably not too many, but a lot of papers on this whole trial relating to EPA alone. And then strength came along, and Preston Mason and I kind of looked at these three trials and tried to decide why one was positive, one the other. And ultimately, we came to the following conclusion, that elevated TGs are associated with, but not really causative. Icosapent ethyl, highly purified EPA, was recently shown to be beneficial both in GELIS and in the REDUCER trial. And maybe there are different properties about EPA than DHA. And this slide is complicated and summarizes that, but that could be impacts on endothelial dysfunction, oxidative stress, inflammation, ultimately plaque growth, and things like platelets and other things that relate to progression. So these are things that EPA increases that are beneficial and decreases that are less beneficial that may all be part. We still don't know why EPA works and DHA doesn't. I think that's an evolving area that needs much more investigation. And Ameren, the company that makes EPA, is not really doing much more science in this area. So this is very disappointing. Now, let's, in close, talk about new kids on the block. This is a drug called olezarsen, which is an antisense ApoC3, where we talked about C3. This is the dose response curve, and people with baseline triglycerides around 500 about the ability of the antisense C3 to lower triglycerides. By the way, there's a history before this of a precursor drug called Boettcher, which ultimately had effects on platelets, lowered platelet levels, which became of concern. And this is the new drug, which has a liver-specific GAL linkage that means that the liver only is impacted by this particular compound in terms of ApoC3 production. This is plozasiran. By the way, this paper is published today. Today's issue of the New England Journal, and of course I get the issue like many of you do a couple of days earlier. Baseline TGs here, 245, ApoB 102, kind of borderline ApoB levels. And here we're looking at another drug that is an ApoC RNA interfering compound called plozasiran, and that has, again, impressive triglyceride-lowering effects. And then here are these class of drugs in a wide variety of different clinical trials in terms of FCS and other forms of hypertriglyceridemia. And at the bottom is anti-angiopoietin-3. Let's talk about that briefly. The angiopoietin-like proteins are genetically validated triglyceride targets. They are important modulators of lipid metabolism. They are circulating proteins synthesized in the liver that modify mostly lipoprotein lipase-related clearance. And here, the angiopoietin-3 coding gene is specifically expressed in the hepatocytes and is regulated by LXR, which drives triglyceride synthesis in the liver. And angiopoietin-3 undergoes cleavage, is mediated by PCSK3 and PCSK6, not PCSK9. And this effect on LPL activity is probably the mechanism by which angiopoietin-3 excess modifies triglyceride-rich lipoprotein. So zodasiran, paper by Bob Rosen, who I mentioned earlier, is recently published in the same issue of the New England Journal, showing here in people with TGs of 246 and ApoBs of 98, the ability to lower angiopoietin-3, to lower ApoB, and to lower remnant cholesterol. And by the way, I didn't mention the plozasiran also lowers remnant cholesterol. So these drugs look very promising in terms of not so much their impact on triglycerides, but their ability to lower ApoB here, ApoC3 in the previous drug, and also importantly, remnant cholesterol, which I think the field thinks mostly is the cause of atherosclerosis in hypertriglyceridemic people. Let's close with severe hypertriglyceridemia. This is an important problem. Familial chylomicronemia relates to a number of etiologies that impact pancreatitis risk, and that's probably the biggest concern for people with severe hypertriglyceridemia. All these people have defects in either lipoprotein lipase gene expression or ultimately products of gene expression that modify lipoprotein lipase downward, including C2, LMF1, GPI, HDL binding protein, and probably we ought to include the angiopoietin genes there too. This is a slide comparing familial chylomicronemia with multifactorial, which by far is the most common cause. If you look at patients that show up in adult medicine who have triglycerides of several thousand, all these people have multifactorial hypertriglyceridemia, severe hypertriglyceridemia, except people who present with FCS are younger. They tend to be leaner. And this whole table, and you can get access to these slides if you want, have probably a rare form of hypertriglyceridemia you don't see in adulthood. Making a diagnosis of FCS is typically a pediatric issue, not an adult issue. Now here's the historic type 5 or multifactorial severe hypertriglyceridemia. These people have multiple alleles that are genetically conferring, polymorphisms that relate to triglyceride elevation. And now they have acquired secondary factors. And I showed you a whole list of drugs or acquired conditions that cause hypertriglyceridemia. Now, the Moulin group in Paris have defined criteria which you can divide FCS from multifactorial. We don't need to go through this, but each of these points here on this slide have a score connected to it. And on the very right, if the score is above 10, FCS is very, very likely. If it's less than 10, but also greater than 8, it's fairly likely, but not clear. And if it's less than 8, very unlikely. This is kind of crude, but yet it's worked pretty well. And unfortunately, there are a few people that fall into indeterminate risk. And I think that's when genes are necessary to measure. And if you're really thinking about FCS, you need to get genes. And the genetic information will then confirm FCS because, by the way, these people can't be treated. There's no treatment other than low-fat diet. Now, here I promised this. It's a detailed slide, but let's go through this. Here's the liver making VLDL on the upper left, and here's the gut making chylomicrons to the right. Here's the way I describe this to patients, and ultimately the annals accepted this for Alan Chait in my paper. Back to basic McKillis-Menten kinetics. Remember freshman biochemistry in medical school? Anyway, so what's the Km of an enzyme? It's a substrate concentration by which half of Vmax is accomplished. Now for triglycerides, you know what that is for LPL and triglycerides? It's 90 milligrams per deciliter, 1 millimolar. So as ultimately triglyceride levels get higher, I'm thinking about a sink where the water is turned on by the faucet that ultimately gets full on the right, lower right. That's saturation kinetics. And so when I said to a patient, your triglycerides are 5,000, well, doctor, I don't understand why they're so high. Well, I think it's because the faucet's still turned on and the sink's full. And your triglyceride levels are how much water falls on the floor. So how do we treat that? We turn off the faucet, right? So to turn off the faucet, we lower fat to less than 5% of total calories. And I treat 90% of people, or did, as an outpatient. And what I do is this. We question is, do you stop all triglyceride-lowering drugs? Because they don't work. They work on VLDL. They don't work on chylomicron metabolism. And they don't work in saturation kinetics. Less than 5% makes the triglyceride levels fall from chylomicrons about 25% per day. So my clinic was on Friday, and so I had people come back on Monday in 3 days to have their triglycerides measured. And based on their level on Friday, I could predict that they're really following the diet, how much triglyceride fall I should see by Monday. And so that really has worked repeatedly for us in the clinic. And by the way, you need a nutritionist who she or he work with you very closely and understand how you're going to approach these patients. Restart medicines for the lower triglycerides when TGs are under 1,000, because that's typically more VLDL, less chylomicrons, and these drugs start to work then. And the drugs work very, very quickly. So if triglycerides don't reach less than 1,000, if the insurance will pay for it in this hospital, I'm not quite sure how you go about doing this, but you hospitalize and control the diet. But I've only had to do this a handful of times over the years. We can do this in the outpatient clinic. Now, if triglycerides are 10,000, you may need to get every 3 days several times to make sure they're really following the diet. And you tell the patient, less than 5% fat's really a restricted diet, but this is only for a short time. We want to, in fact, get your TGs down under 1,000, so now that the drugs begin to work. Now, finally, plasma exchange or insulin is debated whether these are any better than restricting fat to less than 5% of calories. And you can look at a mixed literature in this area. The dietary treatment of moderate hypertriglyceridemia is probably the same amount of fat we would eat normally. I restrict, simple sugars, no alcohol until TGs are under 400, and then only a little bit because alcohol, increases triglyceride synthesis. Fiber greater than 25, and as I mentioned, simple sugars should never be part of any of our diets more than 10% of calories. So what's the bottom line? Let's summarize. Fasting TGs less than 500 decreases pancreatitis risk. So that's one thing we want to accomplish. We need to use current guidelines always to lower LDL cholesterol because we know that that's where the money is for atherosclerotic cardiovascular disease risk. Consider measuring ApoB as an indicator of CVD risk in patients with LDLs that are between 100 and 130 or less. If the LDL cholesterol level is elevated, ApoB adds nothing because most ApoB is in LDL. But for hypertriglyceridemic people, where the LDL is on the lower side, I think ApoB can be very informative in terms of who's at greater risk. So finally, in patients with fasting TGs above 200 and low HDLs, consider a fibrate or omega-3s. But I don't have any evidence to say that lowering triglycerides from 350 to 175 does any good at all in reducing cardiovascular disease risk. I feel strongly that triglycerides don't cause heart disease. They're associated with particles that ultimately, when they're modified, cause heart disease. EPA, I think you have to make your own indication for treatment individualization. FDA now has an indication for EPA alone. But boy, I don't know, that drug's still trade name and expensive. What about over-the-counter EPA only? Well, Mason Preston at the Brigham is very concerned about this, but he's got, a fiddle in the band here, and he's, very, very focused on work with EPA, membrane fluidity, and other kinds of things. So I'm not sure about that, but he would advise against over-the-counter EPA. And finally, we need to treat severe hypertriglyceridemia with very low-fat diets and measure triglycerides frequently in the outpatient clinic. I've been involved in expert witness cases where a doc would see TGs of 2,000 and not measure triglycerides again for 3 months. Boy, that's malpractice. And I think as endocrinologists, cardiologists, even medical students or general practitioners, we can't allow people to go with severe hypertriglyceridemia. The risk of acute pancreatitis increases as TG levels get up, and ultimately, again, acute pancreatitis is 5% fatal. We just don't see most of those in the hospital. And there's the campus I've been privileged to be part of over the years. And again, to give a dog lecture, the third of 4, is a true privilege. So thank you very much for coming today, or if you're in video land out there, very much. Thank you. Right, you're up.
Andrea, you kind of addressed this, but just in terms of the evaluation of either the ApoB versus HDL2 and HDL3, do we need to send it to a fancy lab to get all those analyses, or just using that non-HDL?
No. Fancy lab analyses of advanced lipid testing like liposuction, et cetera, is not needed. It adds nothing. No guideline is indicative of the need to get more fancy lipoprotein testing.
But we should be trying to do more ApoB testing.
Well, most guidelines now give an indication for ApoB, by the way, as maybe a tiebreaker under certain circumstances. They don't specify this as level 1A evidence. So I think the ApoB, my opinion, and I think a lot of people agree with this, although guidelines don't put this front and center, is in hypertriglyceridemic people whose LDLs are lower at goal, I think ApoB can be helpful in defining additional risk. Then my treatment's not triglyceride lowering, it's more drugs to lower ApoB further. Say a patient's on an intermediate dose of a statin, let's say a Torva 20, and their triglycerides are 300 and their LDL cholesterol is 80, and the ApoB is 130, not 80 or 75. I'm going to add ezetimibe, I'm going to add benzpenoic acid, I'm going to lower their ApoB further, and I'm not going to care anything about their triglycerides before that. Because remember, I didn't mention this, the fibrates do not lower ApoB much at all. So if you're lowering triglycerides with a fibrate, you're not getting atherogenic particle reduction or remnant particle reduction to much of any extent. Other questions, thoughts?
Thank you, everybody.
Yeah,
for your
good. Thanks for coming, everyone. Good.
Thank you.